Can we start? Can you put it on your slideshow mode? Okay. Good evening, everybody. Welcome to today's session of ISG PG Clinics. For today's discussion, we have two eminent faculty. We have Dr. Matthew Philip, very senior gastroenterologist and an astute clinician. He was the immediate president of SGA. He stepped down only in the last meeting last month. And he has an avid interest in all forms of advanced endoscopy procedures. And he is the most sought after faculty for almost all endoscopy conferences in India and now abroad as well. Welcome, Dr. Matthew Philip.
Thank you.
He has his formal training from Government Medical College at Toronto. And along with Dr. Matthew Philip, we have Professor Anup Koshi, who is very silent but very academic. He is a very hard-working clinician working as professor of gastroenterology at Amrita Institute of Medical Sciences. He did his MD from Madura Medical College and later DM from CMC Vellore. And he has a lot of publication to his credit. And when I searched his publication, interestingly, I found 2 case reports on obscure GI bleed. I'm sure Dr. Anup Koshi may highlight on those cases as well. Dr. Matthew Philip is currently the chief of Lisi Institute of Gastroenterology, Kochi. Over to you, Dr. Matthew Philip and Dr. Anup Koshi to conduct the clinics.
Very good evening, Dr. Varghese Thomas and the organizers of the ISG PG clinics. And it's always very happy to be a part of it. And probably it's the second or third time I'm coming to it. And when I thought of when Dr. Varghese Thomas requested or suggested the topic of obscure GA bleed, and I wanted Dr. Anup Koshi to be in the faculty because he's an excellent teacher and very good discussant, and he will stimulate the PG students a lot to educate them well. And we have 2 good PG students today for discussing, and the format is like this. We have 2 cases, and these are all original cases, and we will discuss about present this thing. You can start presenting the history and tell your points. Dr. Varghese Thomas will, Dr. Anup Thomas will lead the discussion, and supported by all others like Varghese Thomas and all Dr. JMD and many other senior faculty here. Dr. Cyril, you will take the first case.
Yes, sir.
Dr. Cyril, you are there?
Yes, sir.
Okay, Dr. Tejasvi, you are also there?
Yes, sir.
Okay.
Okay, fine. In case of any technical difficulty, Dr. Santosh will be on standby mode. Okay. And before we start, certain house rules. Please do not prompt the answers when a question is asked to the resident. You can you can ask any questions and comments subsequently. And please keep all the people other than the faculty and the discussant, please keep the audio and video in the off position. This is to improve the experience of hearing it as well as viewing it. Over to the faculty.
The case 1. Cyril, can you just take up that?
The 20-year-old male, symptomatic since the last 2 months, 2 episodes of melena, maroon colored stools, no hematemesis. How will you elaborate the history? So I would like to know regarding trying to quantify the level of upper GI bleed, whether the bleeding was associated with any postural giddiness, any syncope, and whether he had dizziness during 1 episode, then whether he had any prior history of recurrent belching, reflex, any history issue of any acid peptic disorder, any abdominal pain which was dull aching, or any postprandial abdominal pain, whether any history issue of a gastric ulcer or a duodenal ulcer, or a lower abdominal pain. So mainly whether it was a right iliac fossa pain, whether there was any loose stools during the episode, during the intermittent period, whether he had any history of any loose stools or any weight loss or any significant fever. Then um, uh,
Anup, you want to comment on what are the questions or the points you want to discuss? Can you just comment on that?
Why did you want to ask for history of fever in this case? We're telling history of fever, no?
any low grade fever like an IBD, or though with TB it's rare to have bleeding, but still I will, since young male with melena, um, um,
Okay. And
mild
what
lower
about
abdominal pain,
right iliac fossa pain? Specifically, you asked for right iliac fossa pain?
any ileocecal pathology like any Crohn's disease, or any like a young boy with two, like any Meckel's diverticulum, usually presence in young males, predominant males, any Meckel diverticulum which is bleeding intermittently.
So how does the Meckel's
Or
diverticulum typically bleed? What is the history? Meckel's diverticulum typical history will be?
usually a large hematochezia, a massive bleed.
Okay. Is it usually painless or painful? Bleeds episodes are usually painless or painful? Usually, typically.
Usually painless bleeding.
Okay. Okay. And what is your asked for history of fatigue? What does it mean?
Dr. Anup, can you be a little more louder? Can you be closer to the computer?
Sure, sir. Sure, sir.
So fatigue as a part of a systemic disease, a chronic disease, fatigue can be part like an IBD, or even though rare, as I mentioned, ileocecal TB. Fatigue, just what I though not specific, like a non-specific, indicating a chronicity or a systemic manifestation.
Okay, sir. So this case, you mentioned there is history of melena as well as some maroon color stools. No? So where do you think the is most likely source of bleed? Is it upper GI or lower GI?
Since he had dizziness during the bleed, it could still be a upper GI bleed, but there was no hematemesis, but maroon colored, so I could still place it into a right colon or a lower GI.
Lower GI. Okay. So till where does till where, from what point of bleed does melena occur? Usually, you have history of melena. So what is your usual site of bleed in your melena?
Usually an upper GI above the ligament of Treats, but even in small bowel, it can
Yeah,
have.
small bowel and even right colon. Okay. Right colon also. Okay. Sir, we'll move on, sir.
Sana, I just want to ask one small thing to Cyril. When you get a GI bleed like this, as Dr. Anu was told, one is to find out what is the site of the bleed. And second is you have to find out what is the quantity of the bleed. You have to quantify it. And for that, you have to find out the symptoms. Yes, if there's a syncopal attack, that will definitely tell you that this much amount of blood has been lost. And third is you have to find out the etiology of that. And finally, you have to find out whether it is a GI specific disease or it is a part of systemic illness. Isn't it? So you have to ask questions on that. Understand? Suppose a patient says that I have recurrent episodes of epistaxis earlier. I have got some skin lesions. I have got easy bruisability. I have got easily bleeding tendency. So many things, you have to, and also you have to ask about the family history of that. And if it is GI specific, also you can, as Dr. Anub has told, that if it is bleeding from above, they may say that they may have during the episode of bleed, they have a lot of abdominal symptoms, not pain as such. They have got borborygmy and or something like that. That means bleeding from the proximal part of the small intestine. And all these things. And yes, actually he fell unconscious. He developed a syncopal attack in the washroom. What does that mean? How much amount of what quantity of blood he has lost?
At least 10 to 20%, but syncopal attack more than 20%.
Okay. Anup, anything else?
No, sir, we'll move on. Slide.
He had mild abdominal pain, lower abdomen, detected to have anemia, requiring multiple transfusions in 2 months. Physical examination, point to be taken care. I will look for any telangiectatic spots on the lips, any hyperpigmentation, to look for any polyposis syndrome, like look for any polyposis like Peutz-Jeghers, or any stigmata, like IBD manifestation of IBD, oral aphtha, oral ulcers, then pallor, tachycardia to see the significant the level of anemia and the significant bleed. Um, 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 Pedal edema, also like a generalized, also any vasculitic connective tissue disorder manifestations, whether since he's a young male, whether he has any oral genital ulcers, any purpuric rashes, any particular rashes, or any nodules, subcutaneous nodules, or any features, any evidence of arthritis per se. Um, any pedal edema, it could be a part of a systemic enteropathy, diffuse small bowel. So any hypoalbuminemia as an evidence of hypoalbuminemia, any pedal edema, then telangiectasia, hyper.
This is a part of general examination. Then.
And on systemic examination, per abdomen examination, I will look specifically since he was complaining of a lower abdominal pain, whether a lump could be felt in the right iliac fossa, whether how is abdomen per se, then splenomegaly. I'll specifically look for a splenomegaly. It could still be a young male, so ectopic varices also, though the bleeding, it could be still be ectopic varices. Then any dilated veins as a part of varices, evidence of. Then any cardiac per se, cardiac like any AS, aortic stenosis.
Okay.
So, Anup, anything you want to add? You
No,
want
sir.
to-
No, I just want to ask, why did you mention about cardiac valvular lesion?
Aortic stenosis, Hades
What
can
is-
have
Yeah,
angiectasias,
Aortic stenosis leading to?
angiectasias in the.
And okay, I mean, which group of people, which group of patient you find this particular entity, angiodysplasia and aortic stenosis, and both are related to one particular thing. What is that? Yeah, do you find it in 25-year-old young male, or do you find it in 85-year-old person? Which
Usually
is more
elderly.
likely?
Usually elderly people. Elderly.
This is part of aging process. No? Even aortic stenosis is part of the aging process, calcific aortic stenosis, and then they have such people only develop angiodysplasia.
And Varghese, one more thing, in patients with the cardiac illness, they could be on anticoagulants, so you should also. And in the history, you forgot to mention about drug history. One very important thing in that you have to ask whether he had a drug history of either NSAID or not. In fact, I have put it and then I cancelled it. So I thought you will tell about that. Always ask about drug history, whether he had taken some NSAID or some other drugs also. I think that is.
NSAID is anticoagulants, antiplatelet drugs, because many of the patients many of the past middle-aged patients now are on single or dual antiplatelets. It's a very common thing, at least aspirin, no? So history of NSAIDs, so that's very important in GA bleed.
Drug history is very important, okay?
Pallor was present, abdomen, no organomegaly, no tenderness was there. How will you investigate? Investigations, basic routine blood investigations, blood routine to quantify the anemia. I'm expecting a microcytic anemia and as a part of an iron deficiency anemia. HB was 9, W. Then.
Okay, please tell us what all things you will do. Apart, you will do the routine test. We agree that, and then what all things?
Then I look at liver function test to look at the albumin, whether there was any chronic albumin hypoalbuminemia as a part of chronic illness, as well as any protein losing protein losing enteropathy. Then look at the globulin.
You are repeatedly telling about protein losing enteropathy. So it actually directs the examiner to ask you to more questions. So which are the entities which will produce melena or maroon colored bleeding and protein losing enteropathy?
Predominantly connective tissue disorders, vasculitic like Behçet's, systemic lupus.
Cyril, I think you have to be very clear in this one now, because it's a short history illness, and this patient has This patient is present with predominantly GA bleed. There is no history of edema. A person with a chronic protein-losing enteropathy, he will have edema. Here, actually, there was no edema. So I think you should not stress upon, as Professor Varghese said, you should not stress upon which is not there. Okay,
Yes,
you should try to catch up on what are the positive findings there. No, then you try to discuss on or find out something on that. So that will be better for this patient at least. Okay, short history, only 2 months history.
So then,
What are the investigations you have done? You do
coagulation parameters. I'll look at, sir. Coagulation parameters, platelets, PTNR, and APTT. Whether there is any systemic coagulation disorder. Then I will go ahead. If he's a stable patient, then I will go ahead with the upper GI endoscopy, as well as if it is since he had a massive, like it could be still be a massive upper GI because he had syncope attack, and a colonoscopy with ileal intubations.
What percentage of upper GI bleed present with this type of massive bleeding coming through the maroon colored stools, etc.? Upper GI, what percentage of upper GI bleed? Will you do a colonoscopy first, or will you do an upper GI?
I will do a colonoscopy here because of the maroon colored and the right lower abdominal pain. So colonoscopy I will do first. Then if it is negative, then I'll go ahead with the.
Can this be hematochezia?
Yes, sir.
So what are the causes of hematochezia? What is a hematochezia?
Hematochezia is a passing of fresh blood.
Okay, so what are the causes of that?
In this age group, vascular malformations, Delafoy's, then Meckel's bleed, then even inflammatory bowel disease.
Can causes in the upper GI tract produce hematochezia? For example, varices in the esophagus and stomach, ulcer disease of the stomach or duodenum, or proximal small intestinal disease. Can it produce hematochezia?
If it is very massive upper GI bleed, then
okay. So what will be the clue then?
Usually the patient will be symptomatic. Like the patient will have a syncope.
You have all the patients are symptomatic because they are coming with the bleed. That's the most important symptom. So hematochezia will be associated with more of systemic symptoms of hypovolemia, because that signifies a significant bleed compared to a person with a bleed from colon straight away and he has not bled much. There may not be any hypotension. Okay, so large quantity of blood, number one. Two, features of hypotension or blood loss. Okay, those things have to be. And whether it is melena, hematochezia, or hematemesis, the first priority of a person who gave history of giddiness is that you have to examine his vitals, most importantly, when the patient comes to you. Because if the patient is unstable, before going to very detailed history, you have to support him, no? That should be the first step. But if the person is walking and sitting without any problem, probably we'll take a detailed history. Okay, over to Dr. Matthew.
Okay, what's next? So here actually endoscopy is not very contributive, just shown solely. And colonoscopy is normal except for minimal dark liquid stools in the right colon. What will be your next investigation?
If he's hemodynamically stable, then if and video capsule endoscopy is available, then I will next likely do a video capsule endoscopy, because for
Anup, can you just
why do you want video capsule endoscopy and why not something else?
Because upper GI, small colon, both are non-contributory.
Okay.
And we are most likely looking at a small bowel pathology.
Okay. But he has had a significant bleed, no? He's had significant bleed, and you want video capsule endoscopy to the next investigation in this case?
So like the bleeding happened, like if he was hemodynamically stable and like if he is unstable, then I would go ahead with the CT angiogram. CT.
Okay. And before video capsule endoscopy, suppose if you're doing, what will you ask for?
If he had any histories, any past history of any surgery, any history of any obstruction, or
Okay.
any history of any IBD or any medications,
Okay.
then that.
Why do you ask that story?
Medication.
Now, why do you want that particular story? Abdominal pain, past history of surgery, past illness, history of IBD, all those things. Why it's so important before capsule?
Retention of the capsules.
Pardon?
Retention of the capsule. It's a good thing. It's very good.
Fine.
So what will you do?
Either you can do
The precaution.
First, you should do a CT abdomen if you're suspecting such a case, or you can do a patency capsule. You can try a patency capsule and see whether it's passing out. If it's passing out,
What is the principle of the patency capsule? Suppose the patency capsule gets stuck and there is a stricture which we could not diagnose clinically.
it dissolves by itself.
Okay, so it does not produce any problem. Even if it gets stuck, nothing will happen to the patient. Okay.
So Cyril, this patient had significant bleed, and we want to know whether that before doing capsule, how is his GI tract? Suppose you do a small bowel imaging for this patient, you find there is a tumor, for example, a leiomyoma or a cyst or a tumor which actually, or a neuroendocrine tumor. If that is sufficient, or there is a pseudoaneurysm, whatever it is. And so in that case, imaging may be a better option in this patient. It is actually and it is less costly also. Suppose you see something, suppose you have a tumor in the small intestine, you need not have to go in for a capsule endoscopy. You can straight away go for a very more definitive procedure. So delineation of the or anatomical study of the small intestine, and of course looking at the vascular structures will be a very good thing in this patient. So the next investigation, as we thought in the unit, is the best is to go for CT angiography with a CT angio. And as I fully agree with you that if the patient is hemodynamically totally unstable, then straight away go for angiography, either by CT angio. That will actually give a localization. Why do you want to do a CT scan? Is basically you want to know whether we can localize the bleed or we can find out a source of the bleed. And also, suppose you want to do a CT capsule endoscopy, then we will also know something about the anatomy of the small bowel. There is a stricture or something else which we are never anticipated. Dr. Anup, what do you think? Which is your approach?
I will definitely proceed with CT endography with CT angio. See, nowadays nobody goes for direct angiography. See, there are some reasons for that. Because if you are going for a direct angiography, you don't know where the exact source of bleed is. So during when you do angiography, there may be breathing and artifacts, so which may confuse the radiologist. So always do a CT angiography before you proceed with direct angio. Because as Sir told, when you do CT angiography, you may know the source of bleed, as maybe it's a tumor or some pseudoaneurysm, and you will be able to localize the exact source of bleed. Nowadays, CT angiography, you will be able exact source of bleed, you will be able to know. So always proceed with the CT angio before you proceed with the direct angio. In this case, definitely here also you would have done a CT endography with CT angio. In this case, yeah. And one more thing is that when you have a active bleed, if the patient is unstable, he may not be able to take oral negative contrast. So you can just do a IV contrast and do a CT angiography. Here they did CT enterography, that is, he has had a negative contrast. You give orally negative contrast and you do a angio protocol. So, and one thing you need to know is that for every CT, the protocol is different. Here you do a CT angio protocol. So what do you mean by CT angio protocol? So, CTC, for every disease, see, it's not just a CT scan. CT angio protocol means there are 3 phases. One is a early arterial, then again one more arterial and a venous phase. As you do in HCC, there is a multi-phase, 3 phases again, but there's a different phase: arterial, portal venous, and late delayed venous. Here, so every disease has got a specific protocol. So here you want an early arterial, late arterial, and a venous phase with negative contrast. You're giving negative contrast so that to distend the bowel, so that you know what exactly the pathology in the bowel wall is. And why do you give negative contrast Because if the contrast is leaking into the bowel, you should know. If you're giving a positive contrast, you won't know if there is leak of IV contrast into the gut lumen. So that is the principle of a negative contrast, that is CT enterography with CT angio.
I think, Cyril, this has to be stressed upon. Whenever there is a bleed-related CT examination, no oral contrast, totally no oral contrast. You can have a CT angio without any contrast, even without a neutral contrast, negative contrast also, we can do that. But if you want, if you're in this patient is relatively stable, that's why we thought of doing a CT enterography plus a CT angio. And also, why you want to look at the venous phase? Because there could be a bleeding from venous malformations, especially from ectopic varices and etc. Then venous phase is quite important also. That is the reason why we want to solve about venous also. So here actually CT enterography with the CT angio were negative. So what next? What are the next line of investigations? Now we have a patient who has come to us with the GI bleed, and we presume that it is from the lower GI tract, somewhere in the small, somewhere in the small bowel, and colonoscopy normal, upper GI normal, and we did a CT scan which is negative. So still we suspect that the patient can have bleeding from the small bowel only. And in that case, what are the investigations you think about? So before that, let me ask you a question. Other than bowel, any other disease can produce GI bleed like this? For example, other than stomach, duodenum, small intestine, colon, any other disease, any other organ disease, can it present with the GI bleed?
Meckel's diverticulum.
No, that is from the bowel only, no? There are appendages connected to the bowel, no? There are organs connected to the bowel also, no?
Very rare causes of GI bleed. Think of.
We go use. Tell.
Aortoenteric fistula.
Now that is of course it's again connected to the bowel, of course. That's right.
Or if like female endometriosis.
That's all possible. Suppose the patient has what is any pancreatic cause which can present as GI bleed? Any liver disease which can produce, or any biliary system disease can present with GI bleed?
Any hemophilia, hemosuccus pancreaticus.
All this has been. So when you told me about history of liver problem, I thought you are trying to tell that you are going to tell me that I am looking for hemophilia. Then when you told about abdominal pain, I thought you are going to tell us about hemosuccus pancreaticus. Something that's why I thought you are going to tell all these things. Whenever there's a history, you should tell all these things, provided you have an answer for that. Understand? Okay. So what are the investigations you do in this patient?
Here, our CT abdomen was normal, sir. So there was no pancreatic pathology or any liver pathology per se. The next most ideal, if video capsule is available, send video capsule or a Meckel's scan.
Why do you say it's Meckel's scan? So instead of going for this, so the protocol for so let Anu discuss on this. The patient coming with this type of bleed. So how will you approach and how will you teach your students what should be the best approach on this situation?
In this case, this patient has had a significant bleed, and CT angio is not showing any significant thing. So out of the three, where what sir has shown here, endoscopy, angiography, and isotope scan. Angiography, definitely I told we won't do, because the chance of getting a positive result with the angiography is very less, since since CT and angiography has been negative. Endoscopy also, from my experience, if CT angio doesn't show anything, I won't go directly for a endoscopy in this case. And in this case, as I'll always prefer for a next likely cause of a significant bleed, I'll most likely go for a Meckel scan in this case, in view of the age of the patient also. This case, I'll go for a Meckel scan.
So in this patient, he was taken up for endoscopy because, so what are the different types of endoscopy you know about?
Push endoscopy and deep endoscopy, sir. Deep endoscopy can be a double balloon assisted or single balloon or spiral endoscopy.
Better terminology is device assisted endoscopy. And then wireless capsule endoscopy. So when you are asked what are different types of endoscopy, one is the wireless capsule endoscopy, then push endoscopy, device assisted. This can be balloon, double balloon, single balloon, or spiral endoscopy. Earlier it was manual spiral, now it is power spiral. And in this patient, capsule was done because all the options were discussed with the patient. Capsule actually, this is in the small bowel. We are actually going beyond jejunum. And here actually you can start seeing dark colored blood there. So you might have blood and it is, when you go deeper, you could see a dark color towards the cecum. So he was actually taken off for. Next options are between isotope or endoscopy. In this patient, we decided to go for endoscopy. We thought we can, if we see a particular lesions, we can actually look at that. What is the chance of missing Meckel's dilating in CT scan? It is very likely that very commonly you miss in CT scan. So just by seeing a CT scan, if you have not picked up Meckel's diverticulum, that does not mean anything. You can actually miss in CT scan unless even it is a very good radiologist can miss Meckel's. So this is actually a power spiral for discussion of we thought we'll just show you this. Power spiral is also negative. So endoscopy is negative. What next? We have got three options here. Angiography, of course, without any active bleed, we cannot do, and moreover, in this case, it's not indicated. Then comes between isotope scan and LABE. What is LABE?
Laparoscopic assisted endoscopy.
So what will be your take on this?
Since he's not actively bleeding, I will prefer a LABE rather than an isotope scan.
In bleed, what are the different types of isotope scan you can do in a bleed?
RBC tagged technetium protected.
No. See, what is the purpose? Only is to find out the site of bleeding. So when that can be done when there is active bleeding, but in a very small quantity. That is, we have to use RBC tagged scanning, isn't it?
Yes.
The other one is that you have to find out the source of the bleed. For that, you have to do a different type of scan. Okay.
Yes.
For example, you are doing a Meckel's scan. This is actually specifically looking for a Meckel's diverticulum. But you do an RBC tag scan to find out where is any amount of small quantity bleeding somewhere. So you'll know from which area it is bleeding. Anup, you want to comment on that?
Yeah, but I've never seen a RBC tag scan ever being done because in today's practice, I think it is redundant. With such good CT endography and all, I don't think there is a place for.
There is no role. I agree that. I have not done at all because of a set of discussion. I told that isotope scan. There are two types of isotope scan you do in these patients. Okay.
Yes, sir.
So in this patient,
since we are considering a Meckel's as a diagnostic cancer, I would go for a technetium Meckel's cancer isotope.
What does this show? This is an isotope scan. It's a real case. In isotope, in Meckel's scan, what is actually you are looking for?
Gastric mucosa uptake of ectopic gastric mucosa in the Meckel's will uptake.
Why do patients with Meckel's diverticulum actually bleed?
Because of ulceration.
Okay. Ulceration where? Is it the diverticulum which is bleeding or something else?
The gastric mucosa, which is present in the
gastric mucosa won't bleed. So bleeding is from the adjacent small cell mucosa, not the gastric mucosa, not the diverticular mucosa. So it secretes acid and the adjacent, very adjacent small intestinal the mucosa ulceration bleeds.
So this actually shows the lighting up areas. Actually, they have done both the isotope scan and the PET scan. And that actually shows Meckel's diverticulum, which is actually beautifully shown. And it is in the ileum. And it's they show you on the cross-section image, it's showing that it's in the ileum. And also on the other conventional isotope also, it is showing it is in the ileum. There is in that region, there is a uptake area, which could be a Meckel's diverticulum.
The middle panel is isotope scan, no?
Pardon?
The middle panel, the picture is the.
Yeah, isotope scan. This is the PET scan. Okay, this is actually for confirmation. They have done that. It's not meant for that. Okay, now you have seen that. Then how do you manage this patient?
Surgically.
Yes.
Divertical.
So this is the patient. You can see that there's a Meckel's diverticulum, beautifully seen. That is arisen from the ileum, and this is actually brought out, and this being resected out. And histopathology actually showed heterotrophic gastric mucosa, and there was no actual ulceration in that small bowel region, but probably it would have stopped by the time. It actually happens intermittently.
So will all Meckel's scan or Meckel's diverticulum show up in the isotope scan, Meckel's scan?
Or is it an absolute diagnostic test for Meckel's diverticulum?
Diverticulum.
No, sir. Only if there is a gastric mucosa, then only it will light up.
Okay.
I believe in patients where there is Meckel's diverticulum with bleeding, there should be gastric mucosa, so that should be picked up. So in a bleeding Meckel's diverticulum, probably this is a diagnostic, but otherwise it may not be able to pick up.
Pick up, yeah. And what surgery do you do? What surgery do you do? As you told, usually diverticulectomy, but sometimes, as I told, no, the bleeding thing is not a diverticulum. So some people do a partial resection anastomosis of the small bowel also, adjacent small bowel also.
There was a suggestion of lab-assisted enteroscopy. Can we have some details on when we do lab-assisted enteroscopy? Because Cyril told when there is no bleeding, because there is no bleeding, I will do lab-assisted. But I think it is otherwise. When we have no other choice, we have no information whatsoever. We have nothing else other than to do this. Over to Matthew and Dr. Anu for comments on lab-assisted endoscopy.
Cyril, lab-assisted endoscopy is a technique where you actually do a laparoscopy and make an endotomy. Through that, you pass an endoscope and find out to know where the bleeding is. Actually, otherwise, very rarely you use it for some other purpose also. You know, for example, you have got a small bowel disease, you are not able to reach with your conventional endoscope, and you are not getting any diagnosis, or in the era where there is actually small bowel endoscopies are not that popular at that time, or power spiral is not available, or double balloon is not available. In those times, you know, we actually use this type of technique. Earlier, we were using LAPE so many times now. Earlier, now very, very rarely, because you know, when there is no other option, because you are exhausted everything, then the patient is bleeding still. Then in those situations, we use a laparoscopy as such a fan endoscopy. But you know, unless you, pardon, yes.
No, here, see, only one or two cases we have done. We have actually had a laparotomy and then do a endoscopy.
That is operative endoscopy.
Operative endoscopy, yeah.
So earlier people are doing operative endoscopy when you don't get anything. But since laparoscopy has taken over many of the GA interventions in surgeons, you know. So what are other clinical manifestations that can occur with Meckel's?
Like presentation, like appendicitis, recurrent, like severe, typical appendicular right iliac fossa pain, infection, perforation, leak, then an abscess formation. So it can present like with right iliac fossa pain.
I know we can take over. We can ask more questions on that.
Okay. Yeah. Tell me what else. Yeah, as you told, see, it can have. Why do you have a? Why do you say presence like appendicitis?
Like it can mimic like typical right iliac fossa pain.
Okay.
You get signs over there, and it can be mimicker of appendicitis.
Fine. Then what else? What else can happen?
Perforation can.
Actually, what is Meckel's diverticulum? So what can extend? What is Meckel's diverticulum?
In other words, can you tell embryologically what is it?
Omphalum mesenteric.
Okay. It's a remnant of what?
Persistent omphalomescentric.
So it can, does it present only as a diverticulum or something else also? Can something extend between the tip of the diverticulum and the abdominal wall?
Which part of the abdominal wall usually?
Where is it connected from this diverticulum
If
tip?
there is a connection between a mecal diverticulum and abdominal wall, where is it connected?
Umbilicus.
Why?
Omphalomescentric duct. It is a persistent
Okay.
omphalomescentric duct, sir.
Okay.
Supposed to
Vitello-intestinal duct. Okay.
Sometimes a band can extend from the tip of the diverticulum to that. So intestine can torsion around that. That can also cause severe pain. The current symptoms of obstruction. So, yeah.
So it can actually produce bleed, its own manifestation. It can remain silent. You can even say that it's maybe incidental finding. It may not produce any symptom at all. Or it can, clinical manifestations are like, one is bleed, another is diverticulitis, then it can even perforate, then it can produce band-like obstruction. When there is a band, the intestine can, and this can act as a intestinal cause of intestinal obstruction, a band-like and all those things. Even they can rotate around that, the bowel can. Dr. Jayanti is not there, Varghese?
No, I don't think. She's not there.
So when you are asked about macular development, always should know about the explanation of its development. And management options, always it is surgical management. Suppose you get an incidental Meckel's on surgery. What will be the surgeon's approach? Any idea?
Should it be left alone or should be operated?
should be removed, sir.
All patients?
I'm not sure.
What is the general consensus?
See, actually, nobody knows the answer for this. There are some people try to remove it, but when there is a band, always try to correct it. When there is a band,
that is definite. Because
otherwise, and if there is any evidence of peri-diverticular inflammation, and it shows if there is some amount of diverticulitis it has created in the past, is there any telltale evidence of that? Then you should actually try to do that. And usually, a wide mouth Meckel's diverticulum, if it is left alone, so it may not produce any problem. But answer is not clear, but I have referred about that. There is no definite answer on this. And Anup, you want to comment on that?
So see, elderly people, if you can palpate something on the diverticulum, you're supposed to remove that. You can palpate, that is, something is palpable. See, when you see a diverticulum, obviously you can palpate, and you can palpate something on that, you are supposed to remove that. Otherwise, and mostly young, I mean children and young adult children, maybe children or adolescents, you find you can remove that. Beyond that, adults and all, if you palpate as Sir told, if there is a band, or if you can palpate something on that, or if there are some features of some inflammation around that, you're supposed to remove that. Otherwise, just leave it alone.
Dr. Geeta, you are there. What is your experience on Meckel's diverticulum? Are you there, Dr. Geeta? Not there. Some of the examiners, most of the examiners are very old, and they have gone through different stages of development of endoscopy. And before these capsule and endoscopes are available, and even CT angio was available, it was a crude angiography, and probably nothing could be found out. So most of these patients landed upon operation theater, and they used to do what is known as an exploratory laparotomy, and still they won't be able to find. And they used to call medical gastroenterologists to the theater, and they used to ask us to do an endoscopy during the surgery. So some of the all-time examiners may ask you about this. What is the role of upper GI endoscopy? I would say at the moment there is no role. But historically, the upper GI or even colonoscope was introduced, and the surgeon used to sort of advance it by touching the scope through the intestine, and they advance it and try to see what was the lesion in olden days. Okay, But now I would consider it as an archaic technique, and one should not do any surgical procedure using that. There were some questions about, can we use PPI for the treatment of Meckel's diverticulum?
Cyril, there is
No,
gastric mucosa.
No,
So,
sir. The it's not response.
Right.
I think the risk of complication in a Meckel's diverticulum with gastric mucosa, once it is symptomatic, is high, and I think one should not depend upon PPI. I think once it has started manifesting, it may create problem. And there was also a suggestion that Meckel's diverticulum also can go into intussusception.
yes.
Yes.
Can be the head of an intussusception. Okay, so that is another complex. So abdominal pain due to the ulceration, abdominal pain, acute abdomen sort of situation due to this intussusception, then torsion, and sometimes even perforation. All those things can occur. So it can produce acute abdomen, chronic abdomen, GI bleed, all those things, multiple manifestations.
And moreover, when the patient, usually the presentation of bleed with Meckel's is painless. And in this particular patient, no, there's only mild pain, and actually he gets relief after defecation, because it could be because of the colon filling with blood, that actually produces some pain for this patient. And I think, in the learning points in this case is probably, once you suspect Meckel's diverticulum, you could have at least bypassed 2 investigations here. One is that you could have actually, to conserve the resources, you could actually stop, you would not have done the capsule endoscopy, you should not have done the power spiral or any endoscopy. This actually I have shown you to discuss, to bring in discussion on this. And you could have gone directly to isotopes and then removed. But the problem is, many times, if it has come to us in occasions where actually removed Meckel's diverticulum, and the patient again had bleeding. This can happen sometimes. So in certain situations, you have to be make sure. Then you have to do all these things. Otherwise, for all practical purposes, you could have skipped capsule endoscopy and endoscopy in this patient, other type of endoscopy in this patient. Okay, this patient.
There is one more comment about the rule of 2. I remember my anatomy professor teaching us Meckel's diverticulum is seen in 2% of the people, that it is seen 2 feet away from the ileocecal junction, and it is 2 inches in length. I think that is the rule of 2. Do you agree?
Yes, yes.
Yeah.
It's actually taught in anatomy books.
Yeah. Because I remember my anatomy professor saying it. I don't know, I haven't read it anyway, but my anatomy professor has read it, and ever since I remember it like that.
Everybody is taught like that, even by surgical processes. See, one, I think, in spite of all we learn about that 2% of people, we actually very rarely come across a bleed with a Meckel's diverticulum. It's very rare. In fact, that's why I thought of I'll show this case and discuss on that. So I think, we'll move to the next case. Any other questions on this?
And the male predominance is also to be stressed, no?
Yes. I think it's 2:1, I think.
Yeah. Okay, I think this case, I think you have completed it. Thank you, Dr. Cyril. Thank you very much for the discussion. And we invite Dr. Tejasvi from Madras Medical Mission to discuss the second case. Dr. Tejas. Okay, welcome.
Yes, sir. So 58-year-old gentleman, diabetic, hypertensive, and case of coronary artery disease, as well as chronic kidney disease and maintenance hemodialysis. He complains of recurrent episodes of melena since 1 year, noted to have persistent anemia, history of multiple transfusions. He's on dual probably combination antiplatelets, which has been stopped since 1 month. Melena and anemia have persisted.
So from history, what do you think are the possible causes of bleed from this history? Elderly man or 58-year-old man?
Probably he is having an antiplatelet induced ulcer bleed. So.
Okay, then?
So then probably an ulcer bleed.
What else?
Uremic gastritis can cause.
Okay.
CKD patient. So.
Then what else? CKD patient. What else can a CKD patient usually have? slow bleed.
So they might he might be on heparin for dialysis. That
Okay.
may have unmasked some bleeding lesion.
Okay, so what is that bleeding lesion? Typically,
Maybe in angiectasia, sir.
okay, okay,
Yes, sir.
fine, okay,
Angiectatic bleeds.
okay,
Yes. Ulcer bleeds, angiectatic bleeds.
yeah,
And even long-standing diabetes might have led to chronic liver NAFLD-related chronic liver disease and might have led to portal hypertension development and varices. But there is no history of any drowsiness or
recurrent episode of anemia for 1 year, very cell bleed, you don't diagnose?
No,
Very
sir.
unlikely. No? So
unlikely.
I think it's a
Most
small
likely an
bleed.
angiectatic.
Yeah.
And there is no history of decompensation. If it is a cirrhotic man who came with the GA bleed, I would have expected some amount of decompensation by this time.
Yes,
And
sir.
also he has heart disease and he's on dual antiplatelets and CKD patients are likely to have other problems also. They can have platelet dysfunction, likely to have bleeding tendency more. And every time when they have dialysis, this patient is they're using heparin. So if there is any even small lesions which are in the GA tract, they're likely to bleed. So I think these are very important, and we have seen more of telangiectasia in these patients. So what about this? So physical examination.
Yes, sir. Physical examination.
What is the role of general examination detecting cutaneous lesions in systemic disease causing GI bleed?
Systemic disease causing GI bleed. Sir, patient, if it is a related chronic liver disease, we can look for stigmata of chronic liver disease, sir. And if it's a malignancy related, patients can have any cutaneous markers of malignancy, sir. Then, and a patient with coronary artery disease.
Can you elaborate the malignancy and the cutaneous manifestation?
So it could be GI malignancy, sir.
What cutaneous lesion?
So it could be any Sister Mary Joseph's nodule. Then they could have necrolytic erythema, esophageal malignancies. Then
esophageal malignancy, what will you get?
Sir?
Esophageal malignancy, what will you get?
Forgot the thing, sir.
Okay, it is a tylosis, thickening of the plant, palms
yes,
and soles, palmoplantar tylosis. Okay, and
Yes,
necrotic migrating erythema is not seen in esophageal neoplasm.
Glucagonoma.
Glucagonoma, yeah.
Yes, sir.
What other external manifestation can occur in abdominal pancreatic cancer? What will you get? Thrombophlebitis, migrating thrombophlebitis.
Migratory thrombophlebitis, sir. Yes, sir.
Connective tissue disorders.
Yes, sir. We can get scleroderma.
What is the finding on scleroderma?
So we can have calcinosis cutis, Raynaud's phenomenon. There's a CREST syndrome. Yes.
Okay. Microstomia, circumoral fibrosis. Okay.
Then they can also have patchy depigmentation like salt and pepper appearance on patients.
Depigmentation, yes.
And sharp noses, opening difficulty in opening mouth because of the microstomia and disease. Okay. Any other?
So then apart from that, if the patient is alcoholic, they might be having features of alcoholic liver disease.
Agreed. Liver disease we have discussed. So stigmata of liver disease. We are specifically detecting for any cutaneous lesion in relation to GI bleed.
Yes, sir. And here's a coronary artery disease patient. He might have some xanthelasma or
but that is not a coronary disease. We are not discussing coronary disease. We are discussing about GI bleed.
Yes, sir.
We are looking for a clue to the cause of GI bleed by looking at the skin.
Yes, sir.
It can be congenital lesion.
What is this?
So that is buccal pigmentation, sir. Can occur in Peutz-Jeghers syndrome, sir.
Can they present with GI bleed?
Yes, sir. They can have hematomas and they can rupture and bleed, sir.
Okay.
Yes, sir. Yes, sir.
What is this?
So this again.
What history will you ask in this patient? Suppose a patient comes with GI bleed and he has got this physical finding. What history will you ask in him?
This was discussed in the last case, right?
Yes, sir.
Cyril actually mentioned all these things. It was actually repetition.
Yes, sir.
So what do you think? What are the lesions? You try to describe it.
So, there is a subcutaneous.
No, you are seeing the tongue.
Tongue.
Yes, sir. Yes, sir. So, buccal hematomas, sir, minor.
Hematoma does not like. These are
Telangiectasia.
telangiectasias, no?
Telangiectasia, yes, yes, sir.
Okay.
So this patient, you should ask, this type of patient, they have recurrent epistaxis. They have got a family history. So this could be a hereditary telangiectasia or Osler-Weber-Rendu syndrome.
Yes,
And they can also have sometimes on the skin, but mostly on the oral cavity, nasal cavity, and GIT. So they can have recurrent bleed, and many times they present with the anemia also. Chronic blood loss also they can have. This is an autosomal telangiectasia of tongue, palate, and GIT, present recurrent epistaxis, and they can also can have involvement in other organs. What is this?
The left-sided lesion.
Two separate disease.
Yes, sir.
Don't worry, you are doing very well.
Nails, sir. Nail blade bleed, sir.
No, this is a quiz only. I don't think you will get this for your examination. Anyone can put it in the chat box also.
So,
There are two different diseases, one disease and this is another disease.
This is a quiz only, not examination.
this
Blue
is
rubber
acanthosis.
web. Okay, many people are putting in blue rubber web syndrome. Okay.
And the other one is the bleeding below the nail bed, sir.
That's a neck lesion showing multiple papule skin lesions, no?
Yes, sir.
What is can be? Pseudoxanthoma elastic.
Xanthoma elasticum. I think that is pseudoxanthoma elasticum. Okay, because it is skin, we won't elaborate much, but there is a chapter in Schlesinger which is cutaneous manifestations of GA disease. Okay. Okay, there's another chapter on GA manifestation on systemic disease also. I think both you have to be both these chapters you have to be thorough. Okay. Please let us please tell us the causes of melena, recurrent melena.
So, recurrent melena, it could be a peptic ulcer disease, sir, and or else it could be due to any malignancy, sir, or it could be due to IBD, sir, or else much rare.
IBD is such a vague term, no? Can it be ulcerative colitis?
No, sir, Crohn's, sir.
Oh, you have to say then. You have to.
Yes, sir.
Okay, Crohn's disease affecting the small intestine. Okay, but peptic ulcer agree. Okay.
Yes, sir. Then malignancy can cause, sir.
Okay, malignancy where?
Gastric malignancy. Any so malignancy.
Okay, any lesion in the upper GI tract also can produce. So upper GI tract and midgut, both these areas can produce melena.
Yes, sir.
Okay. Can colonic lesion produce melena?
Sir, it can produce, sir. If it's in the right side of the colon and if the transit time is increased, then we can get melena.
How do you explain the melanic color then?
Sir, there. Sir,
no, why there is black color in melena?
Why there is black color in when there is a bleeding from peptic ulcer?
So because of digestion of the heme, sir. And
then what exactly the cause for the color? What chemical change occur to the heme?
Stercobilinogen, sir.
Sorry, it is acid hematin. Okay.
Acid hematin, yes.
You have to be very clear. This is very basic fundamental question which we are asking. So I know it is a slip of your tongue, but please be careful. Okay. And what happens when it is bleeding from the colon? There is no acid. Then what is that substance known as? What hematin is that? It's alkaline hematin, no?
Yes, sir.
Okay. Okay, proceed. So these are the various causes. I think the list is still incomplete. I would say woefully incomplete. I think almost all diseases of the upper GI and midgut can produce GI bleed, melena also.
Yes, sir.
There are umpteen number of causes. No, don't worry about. But you should know the important causes. You should always tell. Okay.
Yes, sir.
And coming to investigations.
Yes, sir. Hemoglobin level is 7 gram per deciliter, a low MCV and a low iron and ferritin levels. USG is showing fatty liver. Upper GI endoscopy is normal. Colonoscopy is showing the melena till ileum. No bleeding point could be identified.
has got significant anemia, and his upper GI endoscopy is normal, colonoscopy essentially normal, and the ileum showed melanic stools. But we could not see any bleeding point at that time. So what will be your next option in this patient?
Sir, I would like to do a capsule endoscopy, sir.
See, all of you are actually so much fond of capsule endoscopy, and previous presenter also told the same thing. We have already discussed what is in this patient. Suppose you want to imaging, why are you hesitant to do that? Is it because of CKD?
It's already on dialysis.
Yes.
Why are you not considering a CT scan?
Rajashri, will you do CT in this patient? Yes or no?
Sir, if we CKD on
Is of
medical
CKD.
management, CKD on medical management, giving contrast might deteriorate his renal function. But if he's already full-blown CKD on dialysis, I think we can go ahead.
That's why we have already told he's on
Okay,
dialysis.
he's on dialysis, no?
Yes, sir. So we can go ahead with the CT angiography, sir.
I think there is some okay. This is a CT scan.
Yes.
Are you able to see?
Yes, sir.
I'll show you the picture. That's better. There is a bleeding. Can you see?
Yes, sir.
That is a leak, no?
Yes, sir.
What is that actually?
It's extravasated blood, sir.
Extravasation.
There is extravasation almost in the proximal ileum. Okay. So you have seen the bleed now. So you know the advantage of doing a CT scan here. Okay.
Yes, sir.
So what will be next option?
So since the bleed is quite significant, we'll do we can do angiographic embolization, sir.
Okay. Then
Sir,
what are the risk of doing an angiography embolization in the bowel?
so it can lead to gangrene of the bowel, sir.
So you have to be very, very careful. You have to be super selective and see that it will not produce any end artery damage. So you cannot conventionally what you do in interventional angiography. But now the interventional angiography is so advanced, they can do that when there is active bleeding. There is active bleeding, and in this patient actually, in the center which actually did this and referred to us, they did an angiogram. It was actually they could not find any active bleeding at that time. In other words, when you will be able to tell an interventional angiography to tell that what amount of bleeding has to be there when to pick up on an angiography?
The amount of bleed that will be picked up, sir. 10 ml, sir.
10 ml means what?
10 ml of extravasated blood, sir.
CT angiogram already shown that there is a bleeding. There is actually extravasation.
0.5 ml per minute.
Anup, you want to add on this anything on this case?
So
No, sir, I think.
No, will you do an angiogram in this patient?
This
What will be
patient-
next? This patient, your CT showed extravasation. So what will be your approach? Tejusi thinks that straight away going for angiogram.
Here,
or else we can even use a spiral enteroscopy and
Not spiral, no. Endoscopy to reach there and see.
means
Dr. Varghese Thomas, what will be your approach in this patient? You are
Can you repeat the question? I was looking at the.
No. Both of you are examiners, Anup Koshi and Varghese Thomas. A patient coming with a CT angio showing a extravasation in the small bowel. So what is the what do you want the student to answer as the next option of investigation?
So extravasation means there is actually active bleeding. Okay, so we have to identify the exact spot because CT angio will not locate the exact blood vessels. So we have to do a super selective angiogram and locate the blood vessel and if possible do therapeutic procedure. Okay, so there is active bleeding. So if we delay the procedure to some other time, perhaps the bleeding may stop, and still we may not be able to find out, because these bleedings are intermittent bleedings. Okay, because this patient has history of recurrent bleeding. It may stop by itself and then come back again. By the time you decide to do your procedure leisurely, the bleeding may stop. The CT has not shown us a structural lesion at all. So the structural lesion is not there. So by doing an angiogram, we will be able to find out what type of lesion it is, whether it is amenable for any angiographic procedure or not. Okay, and if you are not able to again manage by angiographic procedure, we may have to think of something else. That will be my approach. Dr. Anu?
So we'll go for a conventional angio in this case, and at the time of doing angio, if the patient has active extravasation, they'll try to deal with that. If not, we'll go for a next thing. So definitely
That
we'll go
means
for
if there is
conventional angio.
active bleeding, you will try to manage it.
Yeah, we'll go for conventional angio in this case. And at the time of doing conventional angio, there have been cases where there was no active bleed and they didn't do any embolization procedure.
Yeah.
So in such a case, we'll go for the next line.
Okay,
This case, our line will be we'll go for a conventional angio. This case.
Yes, I agree that this patient actually a conventional angiography was done. They could not find any bleed, and that is the patient was referred to us. So in this case, after of course, in patients with this type of bleeding, if you do a conventional angiography, if you are able to identify the bleed, you can actually do something. If that is not there, if you don't see any bleeding, then or if your conventional, your angiography interventional radiologist cannot tackle that, I think the next option would be to do an endoscopy.
Yeah.
Or late. Where actually interventional angiography was the procedure which was done, but this was negative. Understood? So we have got three options here. So we decided to go for interventional radiology and angiography. And since there was no active bleeding, then what next you will do?
Tejasvi, please unmute.
Yes, there are two options now. Interventional angiography, actually a lot of rain, there is a lot of sound here. And interventional radiography, they could not identify an active bleeding at that time. And so they told they cannot do anything. In that case, what will be your option?
I would go for endoscopy, sir.
Endoscopy.
Yes, sir. Device assisted.
Endoscopy. Device assisted endoscopy. Okay. So this is the antegrade endoscopy. This is in the small bowel. What are you seeing there?
There's a bleed, sir. Active spurt, sir.
Not a spurt, but active. But what it is? So what will it? How will you tackle this?
We'll try to.
Suppose you see a bleed like this. What are you seeing there? What are you seeing there?
What is the procedure being done?
So clip has been hemo clip has been inserted, sir. Deployed, sir.
What else you could do with this one?
Apart from that, we could inject adrenaline into the around, or else we could do an argon plasma coagulation, sir.
One is that, and mechanical clipping has got a longer duration of efficacy, and you know that I will come to another question later. And here, this bleeding could be seen very well. So hemoglobins could be applied. So it actually a mechanical bleeding hemostasis could be achieved. Dr. Anu, what will be your comment on this? What will be your procedure on this?
Definitely clipping, because I found that APC doesn't work normally for me. Because APC, just see, when you have a angioectasia, there will maybe the lesion may be a bit deeper. So applying just APC on the surface has never worked for me. I always apply a clip.
So Tejasvi, in which condition APC will be better?
So when
Suppose you get here telangiectasia, very superficial lesion, APC could be good. Okay?
Yes, sir.
Here actually we are not sure what is the depth of the vessel and what is the size of the vessel. So we actually use a mechanical device for. So this is it. So we do a spiral endoscopy. It's an antegrade spiral endoscopy and a hemocopy scan. When you do an endoscopy, you know that you can do it antegrade or retrograde.
Yes, sir.
In this patient, we have seen it is in the proximal ilia. So you can either use a retrograde one and the antegrade one.
Dr. Matthew, we saw only the bleeding. We could not see any gross lesion. So what could be the lesion? What could be the lesion which we are dealing with?
In this case,
dealing
what
with
could be the lesion?
I could not hear. Can you repeat?
This is a telangiectatic bleed, sir.
Dr. Matthew is on mute mode.
अरे वो पेशेंट मैंने डाला था तो गलत लिखा था रिपोर्ट किसका क्रिएटिनिन डिटेल्स था
Someone else says, okay. There was a disturbance. Can you repeat? My question was that we did not find the lesion. We found only the bleeding. So what could be the most likely lesion and how will we proceed?
Probably it is a telangiectatic bleed, sir, because patient had other.
In
features
which
of-
condition? There's your sound is not very clear. Can you
Sir?
make it louder?
Yes, sir. Sir? Hello, sir. Yes, sir. Sir, or else it could be a Delofois, sir. Delofois can come like that, sir.
Only is Delofoil. When there is actually, when you don't see a lesion, there is no
Yes, sir.
ulcer. Then undermining vessel which bleeds, and there can be torrential bleeding also sometimes.
Yes, sir.
Okay. So we did a clipping on that, but unfortunately this patient bled again.
Yes, sir.
So he had a rebleed.
Yes, sir.
So what will you do?
So then
What
I would transfuse blood to at least maintain 10 gram per deciliter and ask the surgeon to resect the segment of bowel, sir, that particular area.
So the options are to go for a surgical procedure because we are seeing the bleeding. So in this case, actually we took a different option
Yes, sir.
because we are very sure that we could handle it very well. So we went through a retrograde route.
Yes, sir.
Because we have missed something else in the other part. And we
Yes, sir.
I think because of the video, I am not able to see the video moving, and Matthew's screen is also frozen. Maybe we will temporarily stop the video, and because the bandwidth I think is less. Meanwhile, Tejas, you told about referring the patient to surgeon, and as it is usual for this bleeding to be intermittent. And with what degree of certainty the surgeon will resect a segment of the intestine? We have not much clue. We know somewhere in the middle of the intestine. Okay, that's
Yes, sir.
okay. So how will the surgeon know which part is bleeding? Because if it is Delofois or angiodysplasia, there will not be any abnormality seen from the serosal side when he look at the intestine. They usually do a survey of the entire intestinal tract, try to see whether there is any major problems, etc. They'll palpate the intestine and all. But in this case, they will not find anything. So how will you guide the surgeon to the particular spot?
So one is intraoperative endoscopy, sir.
Yeah, already done pre-operative endoscopy. So is there anything which you can do?
We could have injected a dye into the
What
around that
dye?
area. Some marker.
Marker. You are correct. You are correct. What are the usual markers which we do? We do markers on clothes. We do markers on various places. So markers on GI tract on endoscopy. What do you generally use? Some ink will be used.
Yes, sir.
It's
Indian
connected
ink,
with
sir.
our country.
Indian ink, sir.
Yeah, India
Indian
ink.
ink. Yes, sir.
Not
We'll mark
Indian.
around.
Okay. That can be injected, which of course will be visible. The macrophages and all will take it to the outside also, so the surgeon will be able to see that segment. Am I right, Dr. Anup Koshi?
Yeah. Yes, sir. Yeah, you
Okay,
also
please
do that.
elaborate. Dr. Matthew Philip has temporarily gone offline. Probably there is an internet problem for him. So we'll continue the discussion. Please carry on. I will try to share the screen from my side.
Okay, sir.
Please carry on with the discussion.
Yeah. So this case, as so sir told, no. So in case you are not able, even suppose you're not done now this thing, you're not patient is bleeding again, and you are not done an injection. So how will you, and the surgeon has taken the patient for surgery. So how will you guide the patient, guide the surgeon in the operative room? What can you do?
They can, sir, they can localize the clip, sir, by.
Okay, clip has fallen off. There is no clip there. Then what can you do? And palpating a clip is also not that easy. You can use intraoperative.
Offline connection login
Hello?
ഞങ്ങൾ കണ്ടിന്യൂ ചെയ്യുന്നുണ്ട്, നമ്മൾ കണ്ടിന്യൂ ചെയ്യുന്നുണ്ട്. നിങ്ങൾ
RBC radio labeled.
No, that has no role. RBC tax, I just told, no, there's no role. Surgeon has already taken, he is planning for a surgery, as you have referred that the patient had bleed to stackle efficiently, then patients again rebleeding with significant bleed. Then you are referring the patient to surgeon. Then how will you guide the surgeon in the operative room? So the surgeon wants to know the exact site, no? Two things. One, the surgeon wants to know the exact site of the lesion. And second thing, not only that, he wants to know if there are similar other sites. See, you have already seen the lesion. It's supposed to be an angioectasia. And you know it is an angioectasia. And patient has rebled with significant bleed. And you have referred the patient to the surgeon. And he is taking the patient for surgery. So how will you guide? And the two things, what to find the site of bleed. Second is, you should know if there are any other similar sites. Because you have not done a full you've done just a CT angiography which showed a probable site of bleed. And on endoscopy and antegrade endoscopy, you have found a lesion and then stop with that. You have just clipped that. But you are not sure if there are other similar lesions. In CKD patient, you can have other similar lesions in the gut. So if at all you're taking, you should do an on-table endoscopy to localize the site of lesion and to make sure there are no other similar sites or no other cause of bleed.
Yes, sir.
It's an operative endoscopy which you should be doing. And
okay, Dr. Matthews, come back.
I'm extremely sorry. Suddenly it went out of this thing. I'm sorry about this. So what we have done is actually we did a retrograde. He had a rebleeding, so retrograde power spiral was done. You can see that it's relatively unprepared because of it could be done very fast. And you could see lesions like telangiectasia spots were seen distal to that. And also on the other side where we actually, these are lesions which we clipped. So there is on the other side of that, there is from the same side, on the other aspect, when we look from the retrograde side, we could see there was some amount of bleeding.
So it's the same site.
Portrayed. This is actually through the back. But ideally agree that when your endoscopy fails or your therapeutic endoscopy fails, then surgery is the best option. But please consider this patient is actually a patient with a lot of morbidities. He has got CAD, he has got diabetes, hypertension, CKD on hemodialysis. So there actually you should try to do an endoscopy procedure as far as possible. That's why we thought of repeating this procedure and we succeeded and the patient is doing fine now.
Yes, sir. Yes, sir.
So when you will tell somebody is having an obscure GA bleed, Tejasvi?
Yes, sir.
What is the minimum criteria by which you can say somebody is having? I already discussed Anup with this.
No, we are not reached here.
No.
We didn't reach here.
So obscure GA bleed is one where a person has a GA bleed, but OGD, colonoscopy, and imaging of the small bowel has not been able to localize the source of bleeds.
Okay, we will call in Dr. Santosh. Dr. Santosh, are you there? Or even Cyril, we can ask a question at random to all of them. Dr. Cyril, have you gone back? Dr. Santosh, are you there? Okay, I think Tejasvi will not take the question.
Yes, sir. So obscure bleed is where overt is where there is either malina or hematochezia, while occult is where only the stool test picks up the occult test is positive. So
What makes it obscure? What exactly, why you call it obscure?
Where obscure is where upper GA and lower GA imaging is not able to pick up.
Imaging?
And, upper GA endoscopy and colonoscopy, sir. Plus now new criteria is even endoscopy, capsule endoscopy is also included.
So what are the chances of a lesion missing on upper GI endoscopy? Or rather, when you do a repeat endoscopy, how many percentage of patients you can have actually you can actually see a missed lesion?
About 20%, sir.
I think that is a little too high.
Yes, sir.
10 or 15 maximum.
Yes, sir.
Okay. So sometimes if a first endoscopy was done and if you are not very happy, maybe it has to be repeated. once again, and then you declare that it is an obscure overt bleed because your patient manifests with the bleeding or you are seeing the bleeding. Okay, next question.
So suppose all the investigative modalities have been exhausted.
Yes, sir.
And so what will be, actually Dr. Varghese has already answered that. Now, when everything fails, then even intervention radiology fails, then you have to resort to surgical aspects. Now, surgical aspect, the simplest one is or the most yielding one is the laparoscopy assisted panendoscopy or operative endoscopy.
Yes, sir.
Okay, and that is actually only when they bleed, you just find out. Otherwise, it cannot. So when they get recurrent bleed and you are not able to find out anything, your procedures are negative. And moreover, now in obscure GA bleed, it is shown that during the episode of bleeding, your yield is much higher. So by the time the patient comes, the bleed would have been gone. Then you whatever investigation do, some days you may not pick up. So when everything fails, I think now this is, and of course you should know about RBC tagged isotope scan, but Dr. Anup Thomas has clearly told the role of it. And it is only a theoretical thing, which rarely people do it now. I don't know Anup is doing or Varghese is doing, I don't know. But it is a very uncommonly done procedure now. Am I right, Anup?
Yeah, we have never done that.
Yeah, I think I'm not. It is
And then
seldom
you
now.
should know about something on laparoscopy assisted panendoscopy or a surgical procedure by which when there is a GA bleed, when you are not able to identify anything. But always in inverted commas, you should actually look for hemophilia as well as hemosuccus pancreaticus, and imaging, a good imaging, a review of the imaging by the radiologist is always very important, and you should have a combination of a multidisciplinary team with a radiologist, interventional radiologist, surgeon, and USL and endoscopist. These are the three people who should be really involved in this and then find out the cause for this. Suppose you see lesions or you don't see anything, and CT is negative, endoscopy is negative, but patient can have bleeding. Is there any medical treatment for telangiectasia?
So thalidomide is there. Then we have long-acting depot.
Your sound is not very clear.
So thalidomide, sir.
Okay.
Then
how does thalidomide act?
So it prevents it's IL-2 antagonist. It prevents neovascularization, sir.
I'm not hearing anything. Anup, are you able to hear?
Yeah.
Inhibits neovascularization, sir.
Is it neovascularization?
Yeah. And so it's actually an anti-angiogenic.
Anti-angiogenic. And we have depot injections of long-acting octreotide also, sir.
Anup and Varghese Thomas, role of empirical medical therapy in those patients where you are not able to do an endotherapy.
Yes, some cases we have resorted to giving thalidomide. Yeah, but thing is, you should know that thalidomide, the main side effect is it causes a high chance of venous thromboembolism. So that should always be kept in mind before you prescribe thalidomide.
Yes. Then long-acting octreotide depot injections, sir.
No.
Is there a role for estrogens?
Yes, sir.
Yes. Earlier, that was a treatment. Before thalidomide, we were only using estrogens. But long-acting sandostatin, is it used?
No.
It's used mostly for neuroendocrine tumors.
Neuroendocrine tumors, yeah.
Somebody has put it in the chat box as bevacizumab. Do you think it is used?
Huh?
In the chat box, there is a suggestion. Dr. Chandrakant, bevacizumab is used. I don't know. I am not aware of it being used for this purpose. Okay. Now, Dr. Tejasvi, how does hemophilia manifest?
So, hemophilia can come with melena.
Okay.
And
what additional symptoms you look for?
What additional features can help you to tell that this could be hemophilia?
Hemophilia.
It could be pain.
Okay, biliary pain, agreed. Okay, then?
Pain, hemophilia.
Why there is pain in hemophilia?
So because of distension of the biliary tract, sir, by the blood.
Okay, anything else?
What happens when biliary tract gets blocked?
So there's jaundice also, sir. Jaundice, melena, and pain.
Okay, jaundice, okay, bleeding, okay, then pain, okay, all those things can occur. Okay, what are the causes of hemophilia?
So it could be a cholangiocarcinoma.
Okay.
More than that, what are the more, see, some procedure which you are doing, which you would have done, will cause hemophilia. What is that?
Iatrogenic
Yes,
causes
sir.
of hemophilia.
ERCP, sir.
No,
More common than.
more common.
Biopsies, liver biopsies, sir.
Yeah.
Okay, that should be your first answer.
Okay. And which situation you have extremely high chance of hemophilia and hemoperitoneum? You have a big liver. You are happy to get a 5 centimeter long liver biopsy.
So when there is a congestive hepatopathy, when we do biopsy, if we do biopsy,
I
then
gave enough clue. You have a huge liver. You got a 5 centimeter long liver biopsy. You are very happy. But next morning, a patient is having GA bleed. Patient is having abdominal distension. Tapping shows the blood. Amyloidosis. Amyloidosis because the blood vessels are not able to contract. No, the normal mechanism of stoppage of bleeding will not work. So that is why it is said that as far as possible, please don't do a biopsy in conventional biopsy in a patient with a huge liver when you suspect amyloidosis. Otherwise, you should have fibrin plug and all other things and do it. Okay, you close that wound which you produce by doing a biopsy, which can be done only under radiographic control.
Another condition when you have got hemophilia is, when portal biliopathy, when you actually do a therapeutic ERCP, some days they can have portal biliopathy, they can bleed also.
What are the other causes? Still, we have not exhausted the list.
Yeah.
Yes, sir. Sir, intrahepatic HCC, sir.
Okay, very rarely. Okay, STC can produce, biliary disease can produce, malignancies can produce, rupture of hydatid cyst can sometimes produce. Dr. Anoop has a case report. I think it was in pregnant patient. You have published when you are a PG student at DM, doing DM. You remember that case?
True, sir. Yeah.
Okay, such cases one will always remember because you would have worked the case so much intensely. Okay, so trauma to the liver due to many causes. It can be liver biopsy, it can be trauma, surgical trauma, it can be traffic accident, and it can be stab wound. So many things are there. Okay, so trauma to the liver, then other diseases which was biliary tree, as well as liver disease which are connected to the biliary tree. So all the things. What are the? Do you have another slide? What are the causes of hemosuccus pancreaticus?
No slides.
Hemosuccus pancreaticus.
So aneurysm, rupture of the aneurysm, sir.
Which aneurysm?
The cyst and rupture of the aneurysm.
What is that known as? Which aneurysm? Is it abdominal aorta aneurysm or some other artery?
No, sir. It is a
branches of the gastroduodenal traversing through the cyst or in the wall of the cyst after a pseudocyst which has been existing for quite some time, and there will be pseudoaneurysm which may produce a bleed. So how does the pseudoaneurysm bleed into a pseudocyst manifest? What are the other symptoms?
So there could be severe hypotension, tachycardia.
Okay, features of a severe bleed. Okay, agreed.
Then sudden enlargement of the cyst, cyst size.
Okay, but before that, the patient will complain of pain, no? If there is sudden enlargement.
Yes,
okay, the pain. And if you do a scanning or physical examination, maybe increase in the size. And on even ultrasound, we may see the change in the characteristic of the cyst content. Okay, all those things.
So, Tejusi, when you do an upper GI endoscopy, how will you know that the patient has got hemophilia or hemosuccus?
So hemosuccus pancreaticus, sometimes the duodenum might be compressed by the cyst, sir.
No, when you do an upper GI endoscopy, esophagus is normal, stomach is normal, there is no blood in that. You go to the first part of duodenum, there is no lesion, there may not be any blood. But when in the moment you go in the second part, there is some blood. So if you see blood only in the second part, always think about either it's from a hemophilia or from a hemosuccus or from a cause from that region, or from it could be bleeding from second part of duodenum as well. And when in doubt, always use a side viewing endoscopy and see whether there is blood gushing out from the embryo.
Okay. Okay, so that is how you will do it. And during the discussion, I think you mentioned about aortoenteric fistula. Aortoenteric fistula, and Dr. Anub again has published a case report, and this is mentioned as one of the rare causes. Dr. Anub, can you just highlight on just a few words about aortoenteric fistula?
See, such cases usually they have obviously has a past history of aortic repair surgery, and they
That means
usually
aortic aneurysm or aortic aneurysm surgery.
Surgery,
That's
yeah.
what you mean.
Yeah, aortic aneurysm surgery, and they usually have a sentinel bleed. That is, initially they have a first episode of bleed, after which second time they have a significant bleed. And when you go, you can see that definitely you can see. Actually, we have published an imaging of that. You can see you can see that actually that a portion of that graft in the third part of the duodenum.
Okay, that means the graft actually erodes into the duodenum. That is the mechanism.
Yeah.
And Varghese, I think it is the proximity of duodenum and the aorta is so close, so the erosion becomes. That is why it is more common in the duodenum.
So which part of duodenum? Third part, fourth part, mostly, no?
So third part of duodenum.
Third part duodenum. Yeah. Okay. Okay, so that is a rare cause. There were some questions in the chat box. Can you look at it before we wind up? Bleeding through ampulla, intermittent, somebody has said. The last question, repeat endoscopy, find out rate is 10%. Is there any role for repeat colonoscopy? Please clarify. This is, I suggested that in a GI bleed, the first upper GI endoscopy can be negative, and you may find a lesion in 10 to 15% of cases on a re-endoscopy, upper endoscopy. But the question is that, is there a need for a repeat colonoscopy before going for CT angio and other procedures?
If it is a colonoscopy was done during an active bleeding, and if there was no lesion found, and there are two situations of not finding a lesion, because sometimes because of severe bleeding, you are not able to see anything. In that situation, a repeat colonoscopy is worthwhile. But in spite of that, you have studied very well during the bleed. If you don't see a lesion, then it's very less likely. But always it is better that a patient who comes with a GA bleed, and I am sure that I will always try to do an upper GI endoscopy. If I think that the bleed was from melena, I will always try to do an upper GI endoscopy and see whether am I missing, or you can say that sometimes you may miss a lesion like dura foci, etc., which sometimes produces intermittent bleeding and all. But in colonoscopy, actually there are no studies as to say. I don't know. I don't remember any studies like that. But upper GI is definitely it is there. I think Anup can highlight on that. But in my situation, many times, when we do endoscopy, we always either go through the retrograde route also. So we'll do a colonoscopy in that aspect, in that way. So Anup, will you repeat a colonoscopy?
If the patient has been referred to us, definitely we'll do, sir. If the patient, many times patient gets referred to us after normal upper and lower GI, definitely you should do a repeat upper and lower GI endoscopy. And not only that, don't trust any outside report, because thing is, the doctor would have seen something, but the report would have been typewritten by somebody else. See, we had a case where the patient was referred specifically for capsule endoscopy by a colleague. So he had as obscure bleed, a CT was done outside and was referred specifically for a capsule endoscopy. So I suggested we repeat an upper endoscopy, but obviously the patient and the bystander were reluctant in repeating an upper GI endoscopy. So we proceeded actually with the capsule endoscopy. What happened was that, see, when you do a capsule endoscopy, you have on the live, you can see the capsule is the position of the capsule as a live.
Can you repeat that sentence?
So what happened was that after
can you repeat that sentence? There was some audio disturbance. Can you repeat the entire sentence? When you do a capsule endoscopy, can you repeat from that?
And when you do the capsule endoscopy, which the machines which come now, you have the monitor where you can see where the position of the capsule is at that point of time. There is a live transmission.
Yes.
So after 3 hours, when we looked, the capsule was still in the stomach. So we did a upper GI endoscopy. So what we found was that there was a stricture, D1, D2 stricture, beyond which the capsule was not passing. So that was not reported in the outside endoscopy. So in this case, we have to cast the capsule with a basket and put it across the D1, D2 structure. So the point I want to tell is that whenever you have a case which is referred from outside, always repeat a upper and lower G endoscopy. We always repeat an upper, and we have many cases, many times we have found lesions in upper and lower G endoscopy, and we have not had to proceed with further investigation. And one more thing which I want to tell is that whenever you do a capsule endoscopy, do in the morning, because see, what we do is we put a capsule, we keep the patient in the recovery room, and we see the live monitor. After 3 hours, if the capsule has not traversed the pylorus, we do upper G endoscope, cast the capsule with the basket, and put it in D2. So never do a capsule endoscopy in the night, because many times the surgeons may ask you to do the capsule at 7 o'clock in the night. Never do that, because then somebody will have to come and look at the live monitor at 10 o'clock in the night if the capsule has not gone past the pylorus, and definitely it's better always to do such cases in the morning, so that you don't have to come in the middle of the night for such a procedure. And many times we have found that the endoscopy would have been done by a good endoscopist, but the reporting many places is written by somebody else. We have seen cases of GJ being missed and have come to us for capsule endoscopy. So always repeat a upper G endoscopy and a lower G endoscopy before you proceed to further investigations.
Okay, there was a question that this particular patient, the second case, was actually having CKD. So is there any role for surgery at all? Because there will be always a recurrence, or it will be managed endoscopically, or is there any role for surgery?
Such cases.
Yes, Anu, tell.
In this case, I think definitely we can manage with all advanced endoscopy, with balloon endoscopy, or even we don't have a spires, we have balloon endoscopy. We can definitely manage such cases. We can go in quite a depth and manage such cases. This particular case, I don't think would need a surgery, but definitely with endoscopically we can manage this case.
Tejasvi, is there? Have you ever reported on a Tejasvi? Are you there?
Yes,
have you ever reported on a capsule endoscopy video?
Yes, sir.
What is the problem?
So problem is the video will be long duration, about 10.5, 11 hours. Sir.
So what will you do?
So normally the up to where we have done the upper G endoscopy will go quickly, sir, up to D2, D3.
You can put multiple screens, one thing, and then put it a little fast. Is there any method by which the system can detect blood and stop?
Yes.
Yes, sir.
There is. It will
Yes,
detect the red color and then stop. Then at that point you go forward and backward and
then again come back. Yes, sir.
Okay. The problem, as you said, the main problem of a capsule endoscopy is watching like an art film with no music and no background music, nothing. Okay, so it is actually a little bit boring. I always feel that unless you are very alert, you may even miss lesions. Long videos, and you have to watch. So if there is an artificial intelligence system, perhaps in the future the reading would be much more perfect.
Actually, the most important, the commonest area where actually artificial intelligence should come is actually capsule endoscopy. Because many places it's not doctors only supervise it. Actually, the technicians or somebody else go through and they select areas, and then the doctor will come and say, yes, this is it, and this is it. So actually, it's a very time-consuming procedure. It's very difficult also. But I think, in bleeding, I think this will help. You can actually look at the color and then actually go forward and backward and look at whether we are seeing any particular lesions or not.
Yes.
Okay. So I think we have come to the end of today's session. Thank you, Tejasvi, and for your discussion. And I thank Dr. Matthew Philip and Dr. Anup Koshi having taken pains to find out the correct case and then prepare it and present it for today's class. I'm sure the students would have learned a lot today. And on behalf of ISG Kerala chapter, I thank Dr. Matthew Philip as well as Dr. Anup Koshi for having agreed to come and take the class for our students. And I also thank Dr. Cyril and Dr. Tejasvi for agreeing to discuss the case today. And also thank to all the students who have participated and all the other faculty members who are there in the background. Okay, thank you. Thank you all.
Thank you for this opportunity. Thank you, Anu, for wonderful,
Thank you, sir.
wonderful discussion and giving a lot of inputs for the students. It was very good. And Tejusi and Cyril, both of you have presented very well. And I think, you should also know about the different types of endoscopes. What is the advantage of the newer one? Whether the new actually will benefit, there is a real benefit over the older ones. Like whether the power spiral is actually superior or not. Power spiral is slightly superior because the time is less. Actually you can study the small bowel very well, but there are disadvantages also. Balloon endoscopy you can practically do in almost everyone except in children. And but power spiral sometimes it may not go through the throat cricopharynx in certain patients because the size of the spiral unit is slightly higher. Some people it may not go through the DJ flexion. But one thing is that if you fail through the oral route, antegrade route, you can actually go through the retrograde route, and many times you can actually need or you can find out the lesions and do that. And there are a lot of therapeutic options also. The scope is relatively shorter, so the therapeutic options are much superior. Okay, then, thank you. Most important thing is the shorter duration time. That is
one question again, last minute question. Single or double balloon, which is better? I think there is no doubt about that, no? Single or double balloon?
Double balloon, no, single balloon and double balloon. That's the question, no? What is it?
No, between single and double balloon.
Double balloon is superior, there is no doubt. Because I was doing single balloon for so many years. I have never used the double balloon except in the initial phase where I had some exposure to that. That's all. We never bought that. And double balloon is definitely superior than single balloon for therapeutic procedures. And between this double balloon and power spiral, I think only the future data will come and tell us what is superior. But what I found is that this is actually a shorter duration procedure. Comparatively, save a lot of time on this. And
endoscopy otherwise takes time, no? But power spiral can do it very fast.
You might have noticed also, actually, we do it underwater. And both the power spiral, all the 3 videos which we have shown actually is done underwater. So actually then it's easier for us to do it. So we do it at underwater power spiral.
Okay, we will wind up the class
Thank you
today.
so much.
Thank you once again. Good night. Good night.
Anu, thanks a lot.
Thank you.
Varghese, thanks a lot. Bye.
Okay, bye. Good night.